So welcome everyone. Welcome to our 5th webinar of the Greater Manchester Women's Health Showcase. And hopefully you've been following us over the last 5 weeks whilst we've been taking you on a journey through some of the most pressing issues in women's health. We started off with inequalities and the social determinants. We moved through to productive and maternal well-being, menopause and pelvic health, chronic disease, cancer, and this is our final seminar on health policy and prevention. We're so fortunate that we've been able to see some of the best research that is currently underway here in Greater Manchester, and we're finishing on a high with all of the aspects of policy and prevention, because as you know, it's more than just research, it's about action, it's about equity, and it's about ensuring no one gets left behind. We know that with everything that's been happening in Greater Manchester, research and innovation is already changing the lives and shaping better care for women in our communities and beyond. Just some very quick housekeeping slides. Please do keep on mute with your cameras off. We have the chat or Q&A function for you, and we very much love for you to ask questions of our fantastic panelists. Please do add to the chat if you have any issues with recording this session, and also the recording will be added to YouTube. The speakers are going to keep to time because we really want to have that dedicated Q&A slot, and I will be giving them a 1-minute warning. And we'll take all questions at the end of all of our speakers presenting. One of the key things with what we've been discussing here as part of our seminar is all of the key policy and prevention messages that's coming through. I'm delighted that we are able to be joined by Jane, Alexis and Elaine, who are going to share their work. Jane's going to start off with the women's health strategy, and then Alexis is going to follow with the Women of the North report, and Elaine's going to show us the Greater Manchester Women's Health Strategy. And so thank you to everyone that's made this possible, and I'm going to hand over to Jane for her presentation. Thank you, Jane.
Thanks, Arpana. Hopefully I've unmuted myself and you can see my screen. Oh, I'm just going to go back.
We can hear and see you, Jane.
Yeah, okay, lovely. So thanks very much. Hello, everyone. I'm really delighted to be here today alongside 3 inspirational women, Arpana, Alexis and Elaine. It's both a privilege and an honour that I'm really grateful for the opportunity to share some work that I was really fortunate to be involved in. So I'm here to talk to you about work that myself and some colleagues in the previously named NHR Policy Research Unit in Older People and Frailty, now renamed Policy Research Unit in Healthy Ageing, that we undertook in 2021. And this was about informing the women's health strategy for England. Can you please just note our funder statement that is at the bottom of this slide? That's just my confirmation that everything I say or views expressed in this presentation are not those of NHR or the Department of Health and Social Care, but my own. So I'm just going to move us on and to contextualise this work. So I just want to take us all back in time to March 2021, when the Department of Health and Social Care launched a large call for evidence seeking views on the first ever government-led women's health strategy for England. This included a Women's Health Let's Talk About It survey that was open to everyone over the age of 16 and an open invitation for individuals and organisations to submit written evidence. They received the largest ever response to a call for evidence that they've ever received. So that was 110,000 written submissions. Upon analysis of the actual evidence submitted, they actually identified that some women were significantly underrepresented, specifically those from minoritized ethnic groups and older women themselves. So in June 2021, they commissioned ourselves as a policy research unit in collaboration with the Prepare facility, which is a large cross-organisation facility that is led by the University of York and the King's Fund. So we worked in partnership, and they asked us to undertake a series of focus groups to address some of the imbalances in the evidence submissions. So as the policy research unit for older people, we led the focus group that specifically was on women aged 60 and over, whilst Prepare covered younger women aged 18 to 60. So we produced an extensive and very thorough joint report, and that can you see there, the report in black. While we also produced as a PRU a shorter summary report on older women specifically and what their needs are. The content of which, or both of those things, fed directly into the Women's Health Strategy that was launched in August 2022. So today, I'm actually just going to really briefly touch on the findings of the work that we did with older women. And our purpose was to really understand their experiences of and priorities for their health and care. It is a really high-level summary overview that I'm going to give you, so do have a look at the reports that we've produced. I will also touch on the Women's Health Strategy briefly, and you can see the relationship between what we did and how that fed into the strategy, but also I'm going to highlight a couple of more recently produced reports that I think might be of interest to you as an audience. That'll feed quite nicely, I hope, into Alexis' presentation on Women of the North, and then Elaine's presentation. So first of all, a quick overview of what we did. So we ran 2 focus groups. We used a virtual platform as it was during the pandemic. There were 14 participants. These are quite small numbers, but we had about 2 months to do it, and that included getting through ethics, which isn't easy. If anybody works in an academic institution, you know that's quite a painful process. We had 14 participants ranging from 64 to 76. More of them, half, were living in areas of high level of poverty, also 64% white British, 36% minoritized ethnic groups. We undertook a very rapid thematic analysis, identifying themes and sub-themes to inform the insights and recommendations into policy. So I'm now just going to run through some of those findings. I just want to mention my co-team there, Gemma, Asri and Barbara, who were involved in our older women's work. So first of all, when exploring older women's experiences of health and care, women talked a lot about not being seen or heard in the healthcare at all. So specifically feeling invisible and relating this to some of the wider social attitudes towards women's roles in society and their voices as well. They also described their experiences of feeling absolutely excluded as they got older. So one example was given where it was very much around the termination of breast and cervical screening in later life, which just made them feel like they were written off because they didn't understand why that happened. Older women also described barriers to accessing care, including short appointments with GPs, which actually for those living with long-term multiple conditions makes it really, really difficult to access the support, the advice, the information that you might need from your GP if you're dealing with more than one condition. And as a result of this, some women just actually felt like they devalued their health. They had feelings that it just wasn't worth the hassle to go to the GP. It felt like it was too much. So if they had health issues, they just remained as unmet needs because they didn't want to tackle or try and get through the health system of itself. In terms of asking women about their priorities for health and care, older women talked to us about being carers and the impact of that on their mental and physical health. as well as some of the financial barriers that really prevent older women from managing their health. So that might include a gym membership, but it also might include money for social activities, being able to get out of the house, actually go and play bingo or go and take part in a social activity, the cinema, whatever that might be, but just not having the money to do it, the things that we know help us live well for longer in later life. Other issues listed here include sexual health in later life and feeling that sexual health was completely overlooked. And also women were just sort of, once they got past menopause, they weren't considered. And other sort of post-menopause health and well-being issues that were related to sexual health as well, but also more broadly about cardiovascular disease, development of arthritis and other long-term conditions that we know affect women post-menopause and in later life. There was a real preference for women's health hubs as a sort of answer to this, but there was a push that actually health hubs that adopt a life course approach to women's health that really recognised issues beyond reproductive life period, but actually instead really addressed health that is actually throughout our later life. So managing long-term conditions, for example, or certain clusters of conditions that are very common to women, or other types of issues that relate to us as we age. So all of these insights fed directly including the wider work as well from the midlife and the younger and midlife group, which Prepare Function delivered. They all were integrated directly into the Women's Health Strategy, which was launched in summer 2022, which you can see here. You can see very firmly they adopted a life course approach to women's health, their needs and priorities. I do recommend you have a look at this because I actually think it is quite thorough in terms of what it highlights is important to women and women's health more broadly. I think it's also good as well in terms of them identifying not only across the life course and the issues that affect women in later life, but also some of those big priority cross-cutting themes that you can see at the very bottom. Sorry, it's not a massive slide, but you should be able to see it. That was around women's voices, healthcare policies and access to services, is about information and education. And we did some further research around how women access information and where they go to trusted sources of information. And finally, health in the workplace and research, evidence and data. So finally, I just want to mention two further global reports, which I think are particularly interesting and you might find helpful. So these were published by the World Economic Forum over the past 2 years. The one on the right there is the blueprint to close the women's health gap. And they've identified 6 pillars as being fundamental to addressing the gap, which are detailed just here along the bottom. So first of all, the importance of counting women and the need to really improve data collection and methods to increase our understanding of what women's health is and what does it look like for us over our life courses. To study women for better research on women's health and the drivers of sex-based differences to better understand this. And I talk about the wider determinants as part of that. Care for women. And this is really around adopting clinical guidelines that align with sex and gender specific care, including enhancing clinical education and care delivery systems, including all women, and that highlights the critical lens of equity and inclusion. And finally, to invest in women. And this is around allocating resource that to advance women's health, but actually goes beyond the usual. So an example of that might be investing in support for women in leadership positions. So finally, just to sum up, I've got here links to all the different reports that I've just run through. I'll pop all those in the chat as soon as I finish. My email's there. More than happy to get in touch, or feel free to get in touch with me afterwards. And I just want to acknowledge again my fantastic colleagues, Gemma, Asri and Barbara, who are all involved in our women's work. Thank you.
Thank you, Jane. A fabulous presentation, and please do use the Q&A. As Alexis is setting up, just to remind you that we will be doing a Q&A session after all 3 presenters have presented. Alexis, are you okay with your slides? And Mike, you're right, changing the spotlight. Thank you. Over to you, Alexis.
Great. Can you see those? Can you see my slides? Let me know.
No. It
okay.
Seems to be sharing your desktop.
No worries. Let me try again. Here we go. Can you see that now? Yeah?
Yeah, but not on presenter mode.
No, I will pop that on now.
Lovely.
Here we go.
Brilliant.
Oh, hang on,
Thank
sorry.
you.
No worries. I'll just go back. I'll just go back one more and then I'm ready. Okay, brilliant. So, hello everyone. My name is Alexis Darby. I am Head of Public Affairs at the Northern Health Science Alliance and also Health Equity North. And I'm going to speak to you today about the work of Health Equity North, focusing on our Women of the North report. So Health Equity North is a virtual academic institute aimed at providing place-based solutions to public health problems. There are three main strands to our work. So there's Health for Wealth, which focuses on the link between poor health and poor productivity. There's Health Resilience, about how we can build a more resilient North, especially post-pandemic. And there's our Child of the North work, where we provide the Secretariat for the Child of the North All-Party Parliamentary Group, which brings together over 20 MPs. And we provide policy for them and also produce reports with them as well. Here are some of our academic team who you may recognise. So we really are experts living and researching, and in many cases growing up in the areas which we are writing about. So our first report, Health for Wealth, which you can see demonstrated here, really showed that there are unique place-based characteristics behind health inequity that we need to examine. We found that people die earlier in the North, 20% earlier, that we're sicker, our healthy life expectancy is lower, and that's lower than those in the South. So when we decided to do our Women of the North report, we really wanted to look at the education levels of women in the North, the types of jobs that they do, how much they get paid, ill health and the health of their families, a real kind of cradle to grave approach, looking at the impact of underlying poverty and also the wider determinants of health from this. And we found that women in the North of England face a double challenge, being held back by both gender and geography. And compared to other parts of the UK, they experience greater inequality when it comes to the conditions which shape health, such as jobs, housing, and access to care. These gaps we found have widened in the past decade, and they are harming life chances and the quality of life. As the mayors Tracy Brabin and Kim McGuinness, who wrote the joint foreword for the report, said that to unleash the potential of women in the North is to unleash the potential of the UK. So it really is time for action. Here's an executive summary of some of the key findings from the report. And it really shines a light on the disproportionate barriers that affect nearly every aspect of women's life. So, we found that with healthy life expectancy, there's a gap of up to 8 years lost between the North and the South, with chronic illness and disability. Long-term sickness is the leading reason for economic inactivity. And also with access to care, there's lower prescribing rates of HRT in the North, despite women facing earlier menopause and longer term health conditions. And we know that women in the North work more hours for less pay than the rest of the country. These slides go into more detail, and I'll make sure that these are shared at the end of the presentation so you can have a look in more detail. But again, when we look at kind of lifelong health, we know that a small proportion of women in the North say their health is good or very good. We know that there's more families in the North on universal credit, and that poverty compounds health outcomes, especially for women with children and or long-term health conditions. When we look at women in work, we can see that women in the North are more likely to be economically inactive, and that's due to ill health. And this is an estimated cost, an economic cost of around 400 million a year. We know that with the wage gap between the North and South, that Northern women lose out on 132 million every week. And when it comes to pregnancy, maternal obesity is the highest in the Northeast at 27.1%. Stillbirths are more common in deprived areas and among Black and Asian women, and that smoking at booking appointments remains higher in the North. When we look at domestic violence, rates of that are higher in the North. And a real stark statistic which stood out for me is that more women die from drug use in the Northwest than men in London or the Southeast. We also looked at ethnic minority women, and we know that they report poor physical health in the north compared to their peers in the south. And, you know, we're all facing an under-resourced health system. So this data really paints a stark and quite heartbreaking picture when you go through it. So we really needed to think about, you know, what can we do? So the report has recommendations for combined authorities, central government and health systems. And we're calling on regional governments, so combined authorities, to target carer support in deprived communities, to expand adult education funding, and to support women into stable jobs with the living wage. With central government, we want them to deliver a national health inequality strategy. I know that Wes Streeting, just earlier today in Blackpool, has spoken about more funding for the north, where they seem to recognise that there are these inequalities. We're calling on central government to scrap the 2-child limit and other sanctions around benefits, to reinstate grants for pregnant women, to ban 0 hours contracts, and really importantly, to build a sustainable childcare system that's supported by family hubs. And with health systems, we are calling for more funding for women's health hubs across the north, to improve ethnic and demographic data, and to ensure that services are culturally sensitive and trauma-informed. I just wanted to talk a bit about the impact of this report. So we launched this report in Parliament, where we had over 10 MPs attend, which was fantastic. And Mary Foy, who's an MP up in the northeast, held a Westminster Hall debate on the key findings of the report, which the then Health Minister Andrew Gwynn attended and promised to share the report with his colleagues in the Department for Health and Social Care. We have the backing of the 2 female mayors, which is great. They wrote the foreword to the report. They also attended a roundtable we held at Labour Party conference, where we had Jess Phillips, the Minister for Safeguarding and Violence Against Women and Girls, attend, which was brilliant. So we really have been doing all we can to not let this report just kind of sit on a shelf, but to keep advocating for change. We recently held the Women of the North Summit in Durham, which Tracy Braben and Kim McGuinness attended, and we had over 200 delegates as well. And from this, we've created our Women of the North Charter, which we're asking all the metro mayors, the northern metro mayors, to sign up to, which says that they will enact the policy recommendations within the report. We also worked really hard to get the report out across national and regional media to highlight the change that we want to see. And these are just a few examples of outlets that covered the launch. And we also received a Buy An Hour award for the report as well, which was great to be recognised amongst our peers for the work that we're doing here. And we know that women in the North are resilient, but, you know, resilience shouldn't be a requirement for a healthy life. And I think we need to stop expecting them to carry this burden alone. We need to speak out, kind of demand action, support the recommendations, because when we invest in the health and well-being of women in the North, you know, we invest in the North's future and its prosperity. And that is the end. Thank you very much. And there's my email address if anybody wants to get in touch after this and find out any more information about the report and the work we've been doing.
Thank you, Alexis. That was great and lovely to see our northern universities shaping women's health and policy, as well as the prevention side of things. Thank you. Just a reminder for Q&As as we invite Elaine to kindly give her talk now.
Thank you, Arpana. I'm
Elaine.
just gonna share my screen, hopefully, and I'll put it on from the beginning. Oops, yes. Hopefully, you can see my screen.
Certainly can hear. We can hear and see you. Great. Thanks,
brilliant.
Elaine.
Thank you. So thanks for the introduction, and I appreciate being able to share this platform with the other wonderful women who've already spoken and the host. My name is Elaine Mills. My contact details are at the end of this slide. I work for NHS Greater Manchester, the Integrated Care Board, and what I wanted to talk about today particularly was around how we involve women in shaping the future of healthcare and support for women. Women are different, not only, you know, by gender and geography, but we have other characteristics which makes life life can be difficult, and barriers for different groups of women. And so the aspect of the Greater Manchester Women's Health Strategy that I wanted to talk to you about and share some findings from was the way we have involved women in those conversations about women's health needs, particularly as they relate to the development of the women's health hubs. So just to put it in a bit of context then, as a public sector organisation, NHSGM has a requirement to have equality objectives. We have 3 broad headings for our equality objectives around our people, our communities and insight, and improving outcomes in terms of service delivery. The particular equality objective I wanted to focus on today was around our communities and insights. And we have an objective to engage and involve communities, particularly those who experience discrimination and disadvantage in the planning, design and delivery of health interventions. And my role is an involvement lead in the equalities function within NHSGM. So that's the sort of policy lever for doing this work with women in communities. And as has already been highlighted by previous speakers, we know that women on average live longer than men. However, women tend to spend significantly greater proportions of their life in ill health and disability when compared to men. Not enough focus is placed on women-specific issues such as miscarriage or menopause, and women are often underrepresented when it comes to important clinical trials. This has meant that not enough is known about the conditions that not only affect women, but are conditions that affect men and women, impact women differently. And whilst women make up over half the population, historically the healthcare system has been designed by men and for men. Hence why we've now got a national women's health strategy, which Jane outlined earlier. So the government's women's health strategy, it sets out how the government will address those disparities in healthcare experienced by women. The government plan set out how it would do, what it would do. It wants to boost health outcomes for women and girls. It wants to radically improve the way in which the health and care system engages and listens to women and girls. And it will do this in the following 4 priorities: by taking that life course approach that's already been talked about, by focusing on women's health policy and services throughout women's lives. It's about embedding hybrid and wraparound services, such as the women's health hubs, and in boosting the representation of women's voices and experiences in policy making and at all levels of the health and care system. In Greater Manchester, we have had a set of priorities in developing our Greater Manchester Women's Health Strategy that came about in response to the National Women's Health Strategy. And I can share the wider Greater Manchester Women's Health Strategy with anybody who would like to see that. But our priorities are around placing diverse women's voices at the centre of health and care, to understand their intersectional experiences, through a women's health network that's been continually being developed. We have a priority around improving the quality and accessibility of information and education on women's health. Our 3rd priority is about ensuring that our healthcare system understands and is responsive to women's healthcare. And our 4th and 5th priorities are around maximising women's health in the workplace and ensuring research, evidence and data supports improvements in women's health. So as has already been identified, one of the first priorities of the National Women's Health Strategy was to launch this £25 million fund to develop women's health hubs across the UK over a 2-year period. The aim of that was to reduce pressure on secondary care waiting lists, to try and tackle health inequalities, to get women's health dealt with closer to the community, so that women could benefit from that tailored support in one place, in their localities, tailored to meet their needs. And the aim of the hubs was to address that fragmentation in provision that's already been talked about, and to improve women's experiences of accessing women's health hubs, women's health care, to prevent or reduce the need for women to have to go from place to place to place to get access to support. These could all be provided in one place in women's health hubs. So women's health hubs were developed across Greater Manchester in the previous 2 years, and they provided a range of services around menstrual disorders, contraception, the fitting of pessaries, and managing menopause symptoms. Those services were delivered and designed with specialist and community knowledge and insight. And in many cases, the GP services were already developing delivering elements of these services, but the health hubs have added value to what's already in place. So the aim of the hubs was to increase that access to services, reduce the unmet need, improve patient experience, improve outcomes and reduce health inequalities, and improve access to information. So in terms of our priority, women's health strategy priority for Greater Manchester around placing diverse women's voices at the centre of healthcare, when we started to develop the women's health hubs in Greater Manchester, we brought together a number of community organisations, such as the Black Health Agency for Equity, MIST Bolton, which is a mental health organisation, and the Greater Manchester Women's Support Alliance. We wanted those organisations who work with women at grassroots level to reach into those communities to deliver focus group activities with women who they currently work with, to help us understand the experiences and the barriers faced by women accessing care. And we wanted to really hear the views of women who experience multiple disadvantage, women who experience homelessness, women involved in the criminal justice system, sex workers, Gypsy Roma traveller communities, Black and minoritized communities, disabled women and older women, and those particularly who experience discrimination. The findings from those focus groups are currently being written up into reports and case studies, and they will continue to feed into the new models of care as we roll out and make a case for women's health sustainable gynecological services. The methodology used to undertake the focus group activities was to firstly identify local organisations who have experience and can reach into those cohorts of women who we wanted to hear from. And that was where my role as an involvement lead comes into play. We entered into grant funding arrangements with those organisations to enable them to deliver the activity we've asked them to deliver. And we met with those 3 organisations on a weekly basis to provide support to them to be able to co-design the approach that we took in developing the focus groups. The 3 organisations co-designed the questionnaire that we would use in the focus groups, the data collection form, the timetable of activity, etc. And some of the success factors we found when delivering focus group activities is that different approaches are required for different cohorts of women. So existing engagement can take place where those women are already accessing community services, such as in the Women's Support Alliance centres. Others went out to meet women where they were at, whether they were at ESOL classes, Keep Fit classes in the community, Bangra classes, Keep Fit, for example. And all the cohorts of women we met individually where accessibility would be an issue. So where we needed to use interpreters, including British Sign Language interpreters, other language interpreters, where it was difficult for women to get out into focus group activities, we would pay taxi fares or go and visit those women individually in their homes. So the focus groups, just to summarise, the focus groups engaged 300 women across those 10 boroughs. Those participants reported varying levels of knowledge around women's health services, such as sexual health, menopause, etc. Women who grew up in the UK generally had a better understanding of services available to them and how to access them than those who had moved from other countries. And this is something we really need to consider, particularly in neighbourhoods where we have demographics of women who come from a range of societies outside of the UK. Women described having a basic lack of information around reproductive health, pelvic health, menopause, etc. And women reported challenges, as has already been mentioned earlier in the presentations. Women face challenges accessing or prioritising their own health due to financial reasons, family responsibilities, childcare, working, etc. Health is often not prioritised unless it's a medical emergency, with many women citing difficulties in securing timely appointments, the long wait times, etc., for health seeking. But despite these challenges, many women express an appreciation for community-driven health initiatives, such as women-only exercise classes, cooking workshops, support groups where women could talk and share with each other about how they manage their health services. And those services are considered to be vital in helping them to engage with their health and support. So going forward, as an NHS organisation, we are making the case for long-term sustainable women's health services closer to the community at primary care level. And that is one of the government's priorities for the reshaped NHS going forward. The evidence suggests that this is more efficient for women and in terms of reducing those secondary care waiting lists. The findings from the focus group activities help to provide that evidence base for how we should reconfigure services to address gaps in services and potential areas for future research. However, we are in the middle of NHS reform and we're awaiting the NHS 10-year plan, and that will identify future opportunities for involving communities in reshaping the NHS. So my contact details are there. As I say, there's more information I can share with you about the wider women's health strategy, and I'm happy to take any questions, or please contact me by email as appropriate. Thank you.
Thank you, Elaine. That's so inspiring and so amazing how much you've done in that time. Thank you so much. Elaine, as I have you on my screen, Emily's posted a really interesting question in the Q&A, that how do we ensure when we do go out to our public and our patient groups, and that they do sometimes appear to be overrepresented by the majority and less socially deprived people. How can we make sure that participation from women from other groups are represented in our engagement work?
Thanks for the question. I think for what's proved helpful for us at NHSGM is having a dedicated resource whose role it is to work or to seek out those communities who are largely underrepresented. I think, you know, when we talk about women, we can be seen as one homogenous group. We talk about health, we often mean physical health, and we forget mental health often. So I think sometimes you need to have a dedicated resource whose job it is to remind us that women are not one homogenous group, that we need to be seeking out women's whose voices we seldom hear. But that person needs to be well connected to communities. So somebody who has a relationship and potentially a longer standing relationship in the communities who we're trying to reach out to.
Thanks, Elaine. That trusted person that people can relate to. And I think that's really vital. Thank you.
Just to sort of add to that, if you like, sorry. I think for my role, I mean, I've worked a long time in communities in Greater Manchester, and
Mm.
it is about having those relationships with those
Yes.
community groups who work on the ground with those communities. And as I say, because having that trusted relationship with those communities, they're more likely to want to get involved and engage their participants in the work we're doing.
Brilliant. Thank you, Elaine. Jane, may I ask the same question to you, please?
Yeah, sure. I think I endorse everything that Elaine has said. I think if I give it from a research perspective, I think there's a level of responsibility as academic institutions that we have to make sure that we cascade resource, but actually allow dedicated time to build trust and relationships with community gatekeepers and people that are operating within our localities over long periods of time. I think trust does not build quickly, and it breaks. Once broken, it takes many, many years to recover. So I think there's something about engagement fatigue, which is where researchers know they have to access funding, have to go out and engage with those that are seldom heard and underrepresented, but are doing that not necessarily in, you know, really sort of responsible ways. These take long periods of time to really build trust with communities. I believe for us in the PRU, we cascade resource to community organisations. We give them the power. We go to their meetings. We contribute to their infrastructure. We see them as our advocates and as our allies. But actually, we allow them to do the work that they do really well, which is actually working with the communities and advocating for the voices that are underrepresented. Whereas rather than us going in as researchers, which can sometimes act as an enormous barrier. So it's working in partnership. It's giving time and giving resource to those community organisations that have the trusted relationships. But also what's very vital is to go back and talk to people about the impact of the contribution that they made to your research or to the work that you're doing. And that for me is absolutely fundamental for any kind of long-term relationship. If you don't do that, then you know it's not appropriate, it's completely wrong, and it's breaking down the levels of community trust that we as an institution, but also as academics, have spent many, many years building over time. I mean, Elaine's approach, just that she outlined there, was really proactive and really engaged, and you know, is very much what I would endorse over the course of time. But you must go back and tell people about what happened as a result of their research, because it's not appropriate to go in, get people's contributions, and then not tell them what happened.
Yeah, thanks, Jane. And so often as researchers, we finish one project, or we've not quite finished one project before the next one starts. And we might be creating that system of not keeping our communities engaged in how much they've contributed to us because of the pressures that we have. So it's great that you've highlighted that. And I think what you said really was inspiring in terms of we've got to give up our power if it's not going to be tokenistic. And doing that is really key. Thank you, Jane. Alexis, I wonder if I could ask you the same question on how as an organisation of organisations, what your advice would be for this question.
I think it's important for us, you know, with our research and our reports that we put out, to always make sure we include the voices of people with lived experience. I know in previous roles that I've had, the kind of nothing without us, about us without us. And I think we really try and have case studies. We try and have people involved from the beginning to speak to us, so we can get a real view, not just kind of the academic view, but take their views on board, especially when it comes to policy recommendations, because we're all, you know, Health Equity North is very much about kind of place-based policy and the role that devolution plays, and that people in those communities know what is best for them. And I think that to us is why we really want to include their voices. And as we've tried to do with the Women of the North report, to keep that going throughout, as I said, we don't want it to just be a report that sits on a shelf. We want to keep the momentum going, we want to keep that engagement with policymakers, and we want to keep women involved at every point of that, to keep the academics who are involved and to keep the people in the communities involved as well, and to sort of help drive that change. So that's definitely something that's really important to us, and that we try and work into all of our research and all of our reports, and even with our media work as well, making sure we've got representation from people who have had that experience and know what that's like.
Thanks, Alexis. Evangeline, are you able to unmute to ask your question? I think we've lost Evangeline. Oh, yes. Hi, Evangeline.
I don't think I put a question in the chat.
Oh, we had your hand up. Sorry.
Oh, it was a mistake.
Okay, no problem.
Thank you.
Thank you. So, on to in the chat, Faye has asked, do you have any ideas about how the 10-year health plan out today can address clinicians' lack of training in women's health and expand community health roles to reduce care disparities and support informed choices? I'm just going to go, Alexis, you're on my screen. I just wondered if you'd like to answer any or all of that question first.
Sure, there's quite a big question, isn't it? I suppose what we have called for, how can the 10-year health plan do that? I suppose it's more funding, isn't it? And it's more targeted funding. And as somebody that's worked, I used to work in policy at Manchester as well. Someone that's worked with academics, I would always say, do not put more funding in it as a policy recommendation. But I think it's about targeting that. And as I've spoke about West Streetings in Blackpool, amazing that they've left London. That's fantastic to see. And speaking about kind of redirecting that funding from the south to places in the north that need it, because as we all know, the context for that is the years of underfunding from the north and then the impact of the pandemic that exacerbated that. So I really think it's about seeing that we need to target the places that need it the most, and generally that is the more deprived communities, and there are more of those in the north. I'm busy doing lots of other reports. As I said, we've got one for our Child of the North APPG that we're putting out next week. So my head has been doing that this morning, so I haven't had a chance to look over the detail of it. But I think I know that West Streeting's also spoken about a men's health strategy, which I think some of us, and as Jane said, these are my personal views, not the views of Health Equity North. I feel that maybe more of a focus on women's health, as we know, and as we all know when we've been to the doctors, there's just not as much research into things issues which affect women around kind of gynecological issues, especially. But I do feel maybe that today that's a sign from the Department of Health and Social Care, from the Minister, that maybe they are taking at least the regional part of it more seriously, and whether the women's health strategy and the kind of attention on that will maybe come. But maybe it's a step in the right direction, I would say, from what we've seen today, I hope.
Thank you. Jane, would you like to take that question?
Yeah, sure. I think Erin's just put in the chat, the 10-year health plan hasn't been published today. I think it's not due for a couple of weeks. But I suppose I want to just think about this question. I mean, I think it's a real challenge, and we're constantly told that women aren't listened to, and what does that look like in terms of good clinical behaviours. I think health hubs are one option. A lot of the work that we heard that women were kind of wanting to speak to other women, people that felt that there was a level of understanding. But I think this is multiple in terms of its potential approach. So there's something about educating and training, and as people pass through the training system, giving them a much greater recognition. I mean, there was a few years ago talking that the menopause you know, module was an optional module for GPs. I mean, these things need to be absolutely compulsory. They're part of what we all experience. 51% of the population will experience menopause. 400,000 women a year will go into menopause or perimenopause. That is a huge amount of the population that need to have good clinical care available to them at that time, and also not being misdiagnosed or given a range of different medications that are not to do or not going to help them in terms of their experience. I think there's something quite interesting in your question, Faye, around community health roles. I actually, you know, is there a world in the future where people that are within our communities, our community gatekeepers, the people that are actually having these lived experience, where there's something about, and it's not outreach, and I've not got the right language for it, but where they come into the health system or they come into our education systems to talk about their experience and to talk about what hasn't worked for them in healthcare, and actually how that then could be pivotal in terms of starting to change some of that education line and the people understanding what it is to live in different communities, and actually to feel quite frightened. You know, people have fear around the healthcare system because they've had really negative experiences. I think there's a really long way to go to build trust so people feel that the health service is theirs. I'm not sure what those transition points might be, but I think there's something about our communities as key educators in the way that we train our clinicians, because our
Yes.
community gatekeepers really can bring about change, and they understand what's happening for women and for broader communities as well, not just women, but actually they understand different lived experiences. So that could only be beneficial, I think, from my perspective.
Thanks, Jane. Elaine, same question to you, please.
Yeah, thanks, Arpana. I think the 3 priorities going forward for the NHS, from hospital to communities, from analog to digital, and the third priority around neighborhoods. You know, this is all leverage, isn't it? The clinicians are going to be asking, how do we do that? How do we move people from hospital to community? How do we go from sickness to prevention? I think we saw during the pandemic vaccinations going digital, that, you know, the way to get an appointment initially was digital, and we saw that it just didn't work in Manchester.
Yeah.
We had very low take up, and the question soon became, why are we having such low take up? And then you need that community response to tell you, to inform you why these things don't work, because, you know, we don't have the digital infrastructure, people don't have devices, don't know how to use them, language, etc., access, all the other issues that we identified when it came to take up of the vaccination. And we had to change and do things differently to enable that coverage to increase. And I think we're going to see the same with these new priorities. How do we get people out of hospital back into community? How do we prevent illness? So I think clinicians will be asking, and they don't have those answers because that's not the model they're used to. So there's going to have to be culture change within the NHS if we truly want to deliver on those new priorities that the 10-year plan will be asking for. And I think communities will be vital in that. We need to understand communities, understand what their needs are, and how we can get behavior change and improve access to services. All of that will come from communities, because it's a new world for clinicians. So I think we have some leverage potentially with the new priorities of the 10-year plan. Once that comes out, you know, we in GM we will be working hard to think about how best do we get that community insight to inform this changes in practice that's needed.
Yeah, so Elaine, as we have you, Elizabeth's put a link in for the GP CPC, but also this feeling that people don't know what they don't know. So this shift for community delivery in women's health, and can't rely on attending the GP if they don't know that there's a problem. How do we address that within the Greater Manchester strategy?
Yeah, no, that's another really good question. And it was something we found during the focus group activities. When we talked to women about women's health issues, that phrase alone was alien to some women. What do you mean, women's health issues? Because we don't talk about the experiences women have in those terms. So there's something about the language we use within the NHS and how we convey messages to the NHS. But I do think those community connectors, again, going back to Faye's point and the point Jane made about trusted voices in the community, who can be conduits into the community. But there's a real health literacy piece that's needed for us to try to break down that language and the barriers that the NHS currently have that prevent women from being able to access this support. As an example, you know, in my day as a younger woman, we talked about smear tests, and now we talk about cervical screening, and that, it's the language can be a barrier. So it's about how do we break down that barrier, and I think it's those trusted voices in communities who can enable us to do that with communities.
Oh, thanks, Elaine. And just going to ask Jane for a comment on that as well.
I mean, I just, yeah, I think it's the same thing, is that really there's some really interesting international models about, you know, the community health worker role and how they're pivotal in terms of changing access, but also addressing some of the language barriers that exist. I think it's really hard to identify unmet need. You know, I'm a woman in midlife with unmet needs. I know I am, you know, and actually there needs to be, for me, it's more around intelligence that help us understand and also communicate with women in their own language about their life experiences or what they're experiencing in terms of health. And that's the only way we're going to break it down. I mean, I think, to be honest, Elaine covered all the key things there and so articulately. So I'm not sure I can add much to what Elaine said.
Thank you, Jane. That's really great, because we're just coming to the end of our session. I'm just going to share screen, and also, as I share screen, thank the huge number of people, some of whom are on this call today, without whom none of this would have happened. So to Jane, Lindsay, Colette, Mike, and the team, all of our speakers for all of our 5 webinars, and all of our fabulous chairs. It's just been amazing, and we have now got our YouTube channel up, and the first webinar is now on there, and Mike is working very hard to get all the recordings onto it. I've popped some things in the chat because Alexis very kindly did a shout out for Policy at Manchester, and please do use our contact us button and sign up to our newsletter. And researchers working at the university, I'm your FBMH, the Faculty of Biology, Medicine and Health co-director, so really keen to hear from you if you are interested in the policy side. And then a final message about our face-to-face event before our summer recess. And again, thanks to the team that I've mentioned, because we do have women's health as our theme. And due to popular demand, as of 5 minutes ago, we've just reopened abstract submission because we closed it and then people have been emailing. So it isn't too late. You can still submit an abstract, and the link is on our website. So I've put all those links into the chat. But I'd like to just say a huge thanks to you all. The discussions all of the information that we have been hearing about, the work that you're leading on, the work that's influencing, making a difference to women, not just here in Greater Manchester, but nationally and globally. And let's not stay silent, and let's not be in here in 10 years asking what's happened. I think between us, we've got the absolute power and the ability to make the difference for our women and girls across the globe. So with that, huge thank you to you all, and hope you have a lovely summer. We hope to be back in the autumn with some more webinars, but we hope to see you in Manchester on the 9th of July at the festival. And I'm just going to check in with Mike, Colette, Jane and Lindsay if I've forgotten anything. Oh, and Anna did post a resource in the chat as well. Lovely. Mike, can I ask if we can save the chat, please? Thank you. Thank you, everyone.